Yeah. Okay. Now, after the important tachycardia, what narrow QRS is the wide QRS tachycardia. What I'm going to do is not give you an exhaustive talk on different wide tachycardias and their management. On the other hand, I do what my professor in MBBS told me long ago, that whenever you see a disease, try to diagnose two things. And most days, if you do these things, you're for the patient. I believe in that, and that is going to be the way my talk is going to go. Is if you diagnose the commonest and most dangerous thing, a wide QRS tachycardia, is VT. If you close your eyes, if you have a wide QRS tachycardia and say it's VT, most of the time you're right. Now, the other things are rare, need not always be diagnosed. If you can exclude a clinician, exclude a wide QRS tachycardia VT, you have done your job to a large extent. Now, let us see. By definition, a wide QRS tachycardia is whenever you have a heart QRS duration on the ECG of 120 milliseconds or more and a heart rate of 120 or more generally. Now, the wide QRS tachycardias can be, if you look at the ECGs wise, this is not the classification on the pathophysiology or the electrophysiology, but if you look at the ECG, you'll see a polymorphic or a monomorphic which is regular, or a monomorphic which is irregular. So three important things. Polymorphic by itself is irregular. Monomorphic is the same kind of QRS complexes, but they're regular. You could have a ventricular tachycardia or a WPW syndrome causing a pre-excited tachycardia, SVT with aberrant, and SVT with pre-existing IVCD. In all these things, these other things are not so important. What is important is to exclude a VT from a monomorphic regular tachycardia and then ask a specialized person. That is, a fairly good enough for a clinician. And the last one is a monomorphic irregular. We're going to talk about these two. Now look at this VT. If you look at this strip in the ICCU, these are one of the most dangerous strips that you can see. The QRS complexes are not only irregular, but they are different in size and different in morphology, and they're different in axis. So this is a polymorphic VT. If you see a ECG like that, there is no need for differential diagnosis. There is no need to think SVT with aberrancy and all this textbook jargon. This ECG is always a VT. You should not generally diagnose anything else. And this generally is caused by two important things depending on the age and the clinical background. Either it could be an ischemia. Typically, a patient with chest pain comes with this ECG, you shock him and then you find an escalation, or it could be a long QT. Now, polymorphic wide QRS tachycardia, as I said, is always a VT. If it is a normal QT, you should still rule out ischemia. If it is QT is prolonged, you should have drugs like amiodarone, electrolytes. You can have a potassium disturbances, magnesium, calcium disturbances, or rarely, if the child who is having this kind of thing is a young person, please remember that a congenital long QT syndrome. So suppose you have a long QT after cardiac, gentlemen, you don't talk about a congenital long QT. You rather think it is an ischemia. Now you see this patient. If you look at this patient had this kind of ECG, and then this went into this kind of ECG. Now what is it here? It's a QRS and is a T wave, a long QT. So, and this T is so prolonged that it is almost coming near the T wave of the next QRS complex. So this is a QT prolongation, and this patient had this kind of ECG, and this gentleman was being given amiodarone in the ICCU. So this is very important, because whenever you see a ventricular arrhythmia, the reflex is to increase the dose of amiodarone. Here you don't do that. Actually, you stop amiodarone when you see an ECG like this. So everybody on amiodarone, please keep looking at the ECGs. Now, mechanistically, if you look at Suchit had spoken very nicely on the different narrow QRS. Now, you can just see mechanistically the very nice I should say the late Masood Akhtar now. Here, one of the excellent gems of papers. One of them is this. You can see that is a narrow QRS tachycardia is narrow. Why? Because it goes through. You could have one reason is you can see the right bundle or left bundle. One of them is blocked. And so what you see is a wide QRS because the bundle is blocked. Now, the other reason why you have wide QRS is pre-excitation. As I said, WPW syndrome. Here you have totally a different axillary pathway. And this axillary pathway does not land in the muscle fibers, in the electrical fibers, but it lands VT, which is arising from the myocardium of the ventricles, either left or right, and that is why you call it white. So if you look at these complexes, these are the general mechanisms of white QRS tachycardia. Here, I am not going into those rare things where you have a fibers coming from the atria to the fascicles of the left ventricle called the atriofascicle or Maheim, because these are rare. Even an electrophysiologist will see probably 2 or 3 Maheims in a year. So let's not go talk about them in detail. I'm just leaving it off for the time being. Now, there are some misconceptions about white QRS tachycardia, which I want to remove. Now, one thing is, every white QRS tachycardia, I told you, the commonest cause of white QRS tachycardia is VT. But having said that, now, can we say that every white QRS tachycardia is VT? No. Look at this. Now, you have a tachycardia like this. Again, if you remember, I showed you a polymorphic ventricular tachycardia with a wide irregular. Now, look at this tachycardia. Again, here the QRS complexes are fairly well formed. They are not unformed or like electrical disturbances, but they are irregular. So, this kind of wide QRS, irregular tachycardia, is always considered of a pre-excitation. When this patient is cardioverted, so all you need is, suppose let us say you are confused. Whether is it a VT or what I'm saying is it's a WPW syndrome with a AF. You lose nothing, just cardiovert the patient. The treatment is same. Once you cardiovert, but don't leave it. Look at the ECG carefully. You don't see here a normal ECG. You see on the other hand a short PR interval in the delta wave. So this is a pre-excitation. So what you see is a pre-excitation. So what you see is a WPW syndrome, and this is the pre-excitation. Now, what you do for these patients is, this patient is a classical candidate for RF ablation. Now, you look at the ECG here. Now, one still short ablation is applied. You see the complete loss of, the fourth wave. The blue arrows is completely loss of the pre-excitation. You can see the fourth and the fifth beat. There is a sudden difference because the pre-excitation is gone, the X-ray pathway is gone, and the person is cured for the rest of his life. This is a very important diagnosis. So you can see from where we have come to where you made a diagnosis of wide irregular tachycardia, cardioverted, found it, pre-excitation, and actually ablated and cured the patient of his life. The second misconception is, if the patient is stable, it cannot be VT. No. 50% of the patients have hemodynamically stable during VT. So if a patient comes to your clinic and sits in front of you with a white QRS tachycardia, that is not the reason you say it's not VT. It could be VT also. Second thing is, if the patient is hypotensive, it has to be VT. Again, if the blood pressure drops, VT. No. Marked hypotension can occur at the onset of SVT to even in structurally normal heart leading to syncope. Look at this patient. This is a young lady who has an EP lab tracing, but see what happens. Now, this is exactly what was like the last talk in SVT. A regular narrow QRS tachycardia, and the lower trace is the blood pressure. The blood pressure is very good, the SVT is going on, but suddenly the SVT becomes a wide QRS because it goes in aberrancy. And then what kind of aberrancy? The V1 is negative, and so you have a left bundle branch block aberrancy. And see what happens when the aberrancy, and also it becomes from a 2:1 conduction to 1:1 conduction, and due to both the reasons, the blood pressure falls. You can see the blood pressure here, suddenly it falls. So that means showing that a narrow, even SVT can also have a hypotension. And this patient used to have recurrent syncopes. So people thought it was a VT and was referred actually for an ICD when they saw this. But actually what we found was an SVT and had a successful ablation. Now, generally, when you have an SVT with aberrancy, these kind of things, if the duration, if the patient has a RBVB, it's more than 140 milliseconds, it favors the VT. If it is more than 160 milliseconds, it favors an LBVB. And the QRS axis is generally minus, in abnormal axis, then you always think of a VT. Now, what are the use? Now, coming to the important points. When you have wide QRS tachycardia, as I said, you have to diagnose VT first. Whether or not you diagnose Maheim, whether or not you diagnose a pre-excitation is not important. Have you excluded VT for the patient? You have done your job, 99% actually. Now, what are the clues to diagnose a VT? It's very important. You don't need to learn a lot of algorithms because you need to know the most important clinical decision-making things. A VA dissociation is the most important. Please learn the VA dissociation, recognize and learn, because it's the most important thing to diagnose a VT. Absence of RS complexes in all precordial leads. I'll show you some of the examples, and QR in one or more leads, and RS more than 100 milliseconds in any precordial leads. And the first and last are very important. Upright QRS in AVR, very, very important sign, generally missed. AVR is the most abandoned orphan lead, it's called. But if you look at some of the things like, a QRS, upright, important diagnosis of VT. Now, if you have a patient like this, it looks like a narrow QRS tachycardia. This is a very, very commonly misdiagnosed. I was doing a different it is not very rarely. I used to diagnose this as an SVT and take it to my professor and say that, sir, this is a patient with SVT. But then the question is, when you have a narrow QRS tachycardia, can you have a VT? We always say white QRS tachycardia is VT. Now look at it. Now what you should see is when you look at you take any lead like V1. Now look at the T waves. You can see alternately, one of them is deep, one of them is shallow. Deep, shallow, deep, shallow. So this should make you suspect that there is an extra wave here whenever there is deep, rather than it is just by chance that you are having an alternate V is big and small. So, and you see the shape of the V wave. Suddenly it changes into very sharp D wave. So there's something happening. So you should always suspect such things. And then you see the proof of the pudding in eating it. I'm going to show you, this is an electrode in the atria. And you see now the same things which I showed you. Whenever there is a wave, P wave, or an atrial electrogram, you can see a deeper QRS T wave. This is shallow, no P wave. And here is a deeper, there is an atrial electrogram P wave. So whenever there is a deep wave, we know that this is a retrograde P wave. Now you can see that there are so many V's, only a few A's. This is a VA dissociation. More V's, less A. Diagnostic of VT, there is no differential diagnosis. Now, second thing is you have a wide QRS tachycardia. Not so wide. You're noting what is this? But when you see a upright QRS and AVR, no RS complex in the precordial leads, V2 to V6, then you should always suspect that it's a VT. You treat it as a VT. Now, QR, a presence of a Q in V1 to V6 is again one of the important criteria to say it's a VT. Now, important thing, AV dissociation. So, in important summary of VT is AV dissociation. I showed you so many examples. A fusion and a capture. A fusion means that you have a beat coming from the SA node conduction system, and a VT is coming from the myocardium somewhere, and both of them fuse to produce a complex which is not so wide, not so narrow. Not so narrow as a normal QRS, not so wide as a VT, that is called as a fusion beat. So a fusion beat is diagnostic of a VT. And similarly, if a wide QRS complex, you see a narrow QRS complex, which is just like a sinus beat, it is a capture. That means in between the VT beats, the sinus node impulse has traveled through the normal His-Purkinje system and captured the ventricle. So a capture beat and the fusion beat indicate that there is a myocardial focus and there is a normal focus. They are both there. So that is again diagnostic of VT. And second thing is, whenever you don't have a history, when a patient comes in the dead of night with no papers, it happens in many of the hospitals. Don't forget to consult page rhythm, because this happened. This patient came with this morphology of one. The ER physician thought that it was a VT and immediately shocked him. And this shock actually did more harm than good, because this shock fell on the T wave and the patient went into VF. He shocked him again. Now, if you still look carefully, there is a spike before every QRS complex. So this patient actually had a paced QRS complex, a pacemaker, not a VT. But this wide QRS complex was mistaken for a VT and shocked. Because I said the commonest cause of wide QRS is VT, but sometimes this can be harmful if you are not observant to small things. Never forget these small things. When the patient was uneducated, he had no papers, he just came in with shock because he had some other hypovolemia or something, and the ER physician thought it was a VT and shocked him. Now, if you have wide QRS tachycardia in ER, now let's take another thing. What is the diagnosis? Now, very important is when you have wide QRS tachycardia, the clinical profile is most important. Now, if you have a recurrent pulse, the patient keeps telling you that for many years, sir, I'm having a, repeated the palpitations for the last 10 years. I'm not saying it doesn't occur, but VT is unlikely. There are some VTs, but it's unlikely. But on the other hand, if the patient tells you, if he had a history of myocardial infarction in the past, or his LV is known, sir, I have a weak heart, or I had heart attack 4 or 5 years back. If he has a wide QRS, make no other diagnosis except VT. Don't even think of any other differential diagnosis. It's VT. So the patient has whatever, dilated cardiomyopathy, mitral valve disease, LV dysfunction, whatever. If he has a white QRS complex, it is VT. Now, ECG in sinus and during arrhythmia is very important. Now, you see, this is the ECG of a patient. Now, I'm coming to some rare things also. This is not very common. Again, electrophysiologists also will see very few in a year. Normal cardiologists may see very rarely, but still you should know. Now, if you have a VT on a person, you can see there is an ST elevation. So this is a young man with an ST elevation and doesn't have a chest pain or anything. This ECG is always like that. So this is one of those repolarization syndromes. This is one of those congenital syndromes of sudden death called Brugada syndrome. And similarly, if you have a double T waves or things like that, and a VF or VT, look at the QT, so long. So never miss in a sinus rhythm, don't miss look at the QT for a patient with white QRS. Always, for few reasons. One thing is this could indicate a long QT syndrome. Now, another thing that in sinus you have to look at is the QS. Now, look at if patient has a white QRS tachycardia, you have shocked him. Look at the sinus rhythm. Now, Brugada and the long QT are rare, but this is very common. So once you shock him, you see QS, you see inferior, there's a Q wave here. And whenever you see an abnormal Q waves in a patient who had a white QRS tachycardia, it means patient had a myocardial infarction in the past. Again, it's diagnostic of VT. There's no other diagnosis. Okay, old myocardial infarction, either by history or by RWMA or by ECG, diagnostic of VT. So sinus rhythm ECG is very important in white QRS tachycardia. If you have a Q waves, it's old MI, it's VT. It's a pre-excitation, I told you. If you have a WPW syndrome, it's not VT. It's a left bundle branch or right bundle, mostly aberrancy. Again, it's not VT. If you have a long QT, it's a VT, and a Brugada pattern is VT. These are some of the examples. And of these, the commonest is the Q waves. And you don't miss up the pre-excitation. Very carefully look at the sinus rhythm ECG for a curable. So this is savable. This is curable. The most are extremely important. Brugada is, you should know, but it's a rare thing. Don't make too many diagnoses. Now, suppose I show you this man's photograph and then ask you, do we need a differential diagnosis for this man's face? Or can you just say, he's Shah Rukh Khan? There are some ECGs like that. You don't need a differential diagnosis, like you don't need to talk about a QA, QRS complex and all that. And these are called as a pattern recognition VTs. Now, I'm going to show two of them. Look at this ECG. Why I'm saying is, here you don't look at white QRS, is a P wave, all these things. Just look at V1. V1 is negative. So it is, and this is a left bundle branch block morphology. The 2-3 AVF are positive. And this patient has got a inferior axis, and you can see the
excuse me, sir.
The QRS complex is slightly.
Sorry for the interruption. 2 minutes of the presentation left, sir. Thank you.
Yeah. Thank you very much. So here you have the QRS, there's a VT, there's a VA dissociation, and then it's a VT and it is a RVOT VT. It's a pattern recognition. Similarly, this again the same ECG which I showed you before, a narrow QRS looking kind of VT, but there is a VA dissociation, right bundle branch block, left, and you can see that typically these are left axis, can also be right axis. But when you have this kind of ECG, it's a fascicular VT. So RVOT VT and fascicular VT are through pattern recognition ET, where you just make a recognition. The another misconception is every white QRS tachycardia need to be cardioverted. No. If a patient walks into your room, is stable, don't just jump on him and without sedation, knock him out. It's dangerous. Second thing is, some older physicians think drugs are safer. Let us give drugs first. If they don't work, let us give. No. Patient, if he is hypotensive, you have to quickly shock him. Otherwise, you may lose the patient if you think that you will give amiodarone first, Zolocard first, and then only you will shock him. So both are different. So it depends on the patient's clinical profile whether you will shock him or no. So in conclusion, I'm going to give you a final algorithm. So white QRS tachycardia, if it is unstable, suppose I'm giving you both therapeutic and diagnostic. White QRS tachycardia, the patient's BP is dropping and he's gone, decivert him. Don't think what is the diagnosis. If he's irregular and it's polymorphic, again, just decivert him. If it's regular and stable, the VT, then you can look at the ECG. If it's regular and stable, then look at the VT criteria, VA dissociation, capture, fusion, are they there or not? And look at pattern VTs, like, the pattern recognition VTs. If they're there, then you can, try out the medications. Pattern recognition VTs, the drugs are either calcium channel blockers or beta blockers. Because the VT of a MI is generally beta blockers and amiodarone. If the VT criteria are negative and then it's regular stable, then you try adenosine or beta blocker, and or if they don't work, you can cardio. Then you can look at the sinus rhythm ECG and see what is. You have all the time in this case. But never forget to identify the following things. Drugs like amiodarone with the white QRS tachycardia, electrolytes, ischemia. Never forget this, especially over 40 years patients, they are missing them. So this is injustice. So patient may not experience it again. Patient can get only once. It is either MI, acute ischemia, electrolyte disorders, metabolic disorders, post-operative. These are the conditions in which the patient has a VT. He may not get it again and again. You have done it. You angioplasty or he may not get it again. But there are some he can get again and again. These are the things which are risk of sudden death, like history of prior MI, structural heart disease, or a specific morphology I told you, and pre-excitation. If it is specific morphologies or a pre-excitation, you can ablate them. If it is history of prior MI, LV dysfunction, or structural heart disease, VT, you have to give him an ICD because it is a dangerous condition. Now, last slide. In conclusion, 70% of the white QRS tachycardias are VT. Please remember that. I re-emphasize them. And do not diagnose an ECG in isolation. That is also a wrong thing. Because please ask the history. Does he have a chest pain? Does he have a LV dysfunction? Does he have a MI in the past? Very, very important. When in doubt, diagnose a white QRS tachycardia as VT. Again, because 70% time you're right. And most important is pick up curable arrhythmias. It is really a disgrace if you don't pick up curable arrhythmias. It's sad to see patients with curable arrhythmias coming in and getting hospitalized, spending lakhs of rupees on overnight admission, like WPW syndrome, RVOT VT, fascicular VT. Please pick up these curable arrhythmias and refer them for radiofrequency ablation. Thank you very much for this opportunity.